Alright, so for this video I'm going to be showing just how I would do a basic biomechanical exam for the feet. So for the first position, I'm going to have my patient non-weight bearing and then seated, and I'm just going to do some quick joint mobility, so checking for just for the talocrural joint, do a quick AP assessment, checking for any pain, and then just checking for hyper, hypo, or normal mobility. And then for the foot, I would check for rear foot inversion, so go ahead and I would just stand up again and check for lateral glide, and then a medial glide. And I can also check for midfoot inversion and eversion, so I bring it in, bring it out. And then I can check for first MTP mobility, so lock down that first metatarsal and just add that superior glide. Also checking for dorsiflexion, and then just the inferior glide for plantar flexion. And with all these, I'm checking for any pain, hypomobility, or hypermobility. Next, I can do range of motion, so just keep it up. Go ahead and pull those toes up for dorsiflexion, push down for plantar flexion, bring it inward for inversion, and then outward for eversion. Then I can also do MMT, shin, push down, push into my hand, good, push out, and good. So next up for prone testing, go ahead and lay on your stomach. So first I would try to find his subtalar neutral. So go ahead and come off the bed a little bit. And then I would palpate for the tip of his calcaneus, which would feel right here. And this would be my midpoint. So then I'd put the goni right on there. Try to get that, try to find what his neutral is. And then I put one arm along the posterior leg and the other on the shaft of the calcaneus. And again, the average should be about 1 to 4, and it looks like it's about 3 degrees for his subtalar neutral. And then for forefoot, I can check out whether or not it's in varus or valgus. So checking for the distal portion of the calcaneus. That's my midpoint going up the leg. Then I would measure along where his second and to fifth mets are parallel. So I'd look down. It looks like his first mets are about 12 degrees. And then next up for static weight bearing, what we'll have the patient do first is just sit down. And what I would do is I'd measure the distance from the navicular to his medial malleolus. There you go, like that. And then I would have him stand up. And then I'd measure the distance between that, usually like from the ground up. And then for the windlass mechanism, what I would do, I would just pull up on his great toe and check for that arch rising up. It looks like it is, so that'd be present for the windlass mechanism. And then for standing subtalar neutral, I would have him stand up. And then I would just look around and see where his talus is for neutral. Looking like it's a little bit, yeah. Thank you.
Yeah.
So it's looking a little bit everted as he's starting to bear some weight on that calcaneus. And then I can also, with this, I can also check for just how he is in standing as well. So from frontal plane, I can check, see how his calcaneus is, a little bit everted, a little over supination, but he is standing on something non-pliant, so that could be the reason why. And then if I go directly behind, I can do toe count, a little bit of increased external rotation on that left side. Looks like I've seen a bit more toes from that than the right. And then any knee collapsing, knee valgus, knee varus. Can you bring your feet in together for me? Looks like the knees are doing just fine, so no valgus varus there. And then from a sagittal plane, go ahead and turn. I can check for any genu rector verum and just see if everything aligns overall. And the last portion of the biomechanical assessment would be gait analysis, but we don't have to do that for the video, so I'm not going to worry about it. And that's the first two components of a biomechanical assessment.